everyone, and welcome back to Blood Matters, a podcast for nurses. I'm your co-host, Emma, and as always, I'm joined by Michelle. Hi, Michelle, how are you?
Hi, I'm great, Emma. How are you?
I'm not terrible. I'm not too bad at all.
Excellent.
So quite looking forward to this podcast. I think we say that every time, but
Yeah,
that's because we have topics that we really enjoy talking about, don't we?
yeah.
So why don't you tell us what we're going to chat about today with our guests?
Well, today we're going to start to cover graft-versus-host disease. I think this will probably be the first of a number of pods on the topic. It's extensive, and there's a lot to talk about. So today, really, we're going to kind of cover kind of a bit of an overview of graft-versus-host disease, and we've got two amazing guests with us today. So I guess without further ado, let's move on. So we have Sophie van Lancker, who's a paediatric nurse, and we have Zinaida Peric, who's a transplant physician. And Zina, would you like to introduce yourself?
Yes, thank you. Happy to be here, and thank you, Michelle and Emma. My name is Zinaida Peric. I'm a hematologist, bone marrow transplant physician from Zagreb, Croatia. I'm interested very much in all transplant complications, in GvHD, but also infectious complications, long-term complications. And I'm the chair of the Transplant Complications Working Party of the EBMT for the last 3 years. So I've been actively involved in many studies regarding these topics.
That sounds
Thank you
amazing.
very
I'm
much,
really
Zina.
happy that you're here. And Sophie, would you like to introduce yourself?
Hi, I'm Sophie. I'm also happy to be here. I'm a nurse, a pediatric nurse of Belgium. Um, I started at the ward at 1969, 1996. For a long time, and I was a long time also a nurse consultant, following the patients from start of the stem cell transplant up to that they moved of go to transition at the adult. So I saw every possible complication in the years I did that. So I'm also the one I'm not favored for, but the one I always find a very big issue is the graft-versus-host. So I'm happy to be here as a nurse for this podcast.
And we're very happy to have you as a nurse, and obviously Zina as a physician. So what we do on the podcast is we'll ask questions, we'll take turns, and then we will bring you both back to the end for the quick fire round. So Michelle, do you want to go first with Zina's first question?
Yeah, sure. Thanks a lot, Emma. So, Zina, I guess people would like to know a bit about what graft-versus-host disease and something about the science behind it. So I think often nurses see the physical effects of graft-versus-host disease and its various manifestations, but perhaps have a little more superficial understanding of the science behind it. And I guess we want to really get down to that a bit, really.
Okay, well, I'll try. I'll do my best.
It's a big question.
Yeah, so I mean, in hematology, many hematological diseases couldn't be cured without allogeneic transplantation. And although we want a donor and recipient to be as much as alike as possible, so usually we say that they are fully HLA compatible, and that is based on some of the antigens that are on leukocytes that we all have. So we want a patient and a donor to be as much as compatible as possible. But although somebody can be fully HLA compatible, there are also some kind of minor HLA incompatibilities, which are actually crucial for the treatment as well, because the effect of the allogeneic transplantation actually lies on this immunological effect that we cannot get with only chemotherapy. So we actually need that little difference to have what we call a graft versus leukemia effect, for example, to get the immunological effect and to get the cure for the disease. At the same time, we cannot avoid the main complication of allogeneic transplantation, and that is graft-versus-host disease. So let's say it is basically the same thing, but focused on the recipient organs. So the one effect is graft-versus-leukemia, so the fact that we have on the disease, and the other one is actually a side effect, graft-versus-host disease. That means that usually those immunocompetent cells, lymphocytes of the donor attack organs of the recipient. So this is basically mostly skin, liver, intestines. And this is something that can be very complicated and can actually cause very severe complications in patients. But we cannot put these two things apart. So we always say that a little bit of GvHD is good, because when we have a little bit of GvHD, we have graft versus leukemia effect as well. And we know if there's little GvHD, there is a bigger chance that the whole transplant thing will actually work. But on the other hand, even though the patient and the donor are compatible, there's always this chance of graft-versus-host disease, and we are never really sure who is going to get the more severe form of graft-versus-host disease and who is not going to get that, but only graft-versus-leukemia. So let's say differentiation between those two, and the one who finds the reason why or the way we could provoke one without another, that would be like the holy grail of the transplantation. So this is something that we are aiming now for already decades. But GvHD is the complication, but we need a little bit of GvHD. That's the point.
Thanks very much, Zina. That's a really, really great overview and very succinctly and beautifully explained. Thank you very much. I'm going to hand over to Emma now.
Thank you. That's so interesting. So how prevalent is GvHD in allogeneic transplant patients? And then what are the kind of morbidity, mortality rates associated with it?
Okay, so graft-versus-host disease actually happens in at least half of all the patients. But as I said before, when I said we need a little bit of GvHD, we usually grade GvHD like grade 1, 2, 3, and 4, and that depends on the, let's say, amount of the damage towards the organs. Let's say grade, most of those GvHD are less severe forms. So grade 1 and grade 2 are the ones that we, let's say, like, because these are the ones that are protecting patients also from relapse. But grade 3 and grade 4 GvHD, and I'm talking now mostly on acute GvHD, happens in, let's say, about 15% of patients, and these are the more severe forms, and unfortunately half of these patients then do not react to immunosuppression that we give them as a cure for GvHD, and some well, let's say a small amount of patients, but maybe 5% or so, can really even die, unfortunately. So cured from allogeneic transplantation, but can die of the main complication, GvHD. We, of course, try to prevent GvHD because there are two things. We need transplant to let's say to be engrafted, to be taken. So we don't want recipient to reject it, and also we don't want the transplant to attack the recipient. So we are just trying to prevent this reaction with immunosuppression. So we give immunosuppression in all patients who undergo allogeneic transplantation, irrespectively of the HLA compatibility. And this immunosuppression is given before transplant, shortly, and then usually for at least 3 months after transplantation. But unlike in solid organs where you would take immunosuppression for life, because it's the other way around. So you have a solid organ and a patient has immunocompetent cells which are attacking the organ, and that would happen forever. In allogeneic transplantation, actually the tolerance between a patient and recipient does occur. So usually after 3 months after transplantation, if there is no GvHD, we know that they have learned to live together. So meaning there are no more recipient cells, and the cells of the donor are not attacking the patient. And 3 months after transplantation, if there is no GvHD, we can stop immunosuppression. So that's good news for transplant patients. They will not take immunosuppression for life. So if there is no acute GvHD in the 3 months, usually it will not occur at all. But then there's a chance of chronic GvHD, which is a bit, let's say, maybe even a different part of transplantation, because chronic GvHD is it's actually completely different. So it looks differently. It's like a chronic autoimmune disease that can affect literally any organ, but the course of it's slower, and there is time to react and time to take care of these patients in a structured way. Of course, chronic GvHD can also occur, unfortunately, in severe forms, but it is more usually in patients who had severe acute GvHD before. But also, even before chronic GvHD, although it usually occurs in the first 2 years after transplantation. So usually if it doesn't happen in 2 years after transplantation, then let's say a patient is usually safe from having chronic GvHD. But even if they have chronic GvHD, also here the tolerance will eventually emerge. So even though this can prolong immunosuppression to even several years after transplantation, usually if the immunosuppression works, the tolerance between the donor and the patient will occur eventually, and let's say those cells will find a way to live together. And then unlike other autoimmune diseases, chronic GvHD will resolve once. So this is something that is good for the patient. But it also has some severe forms, which can also be, well, unfortunately, which can also, because of increased immunosuppression, can cause infections, and infections then can, unfortunately, cause dying as well in patients. But so there is a rate of mortality related to it, but less than for severe acute GvHD forms.
That was a really great explanation. It sounds like a really big balancing act to try and get the patient's graft-versus-host disease not to be too severe. So I commend you all for managing that. Michelle has your next question, Zina, so I'll pass you over to her.
It's I just sort of struck when you were talking, Zina, it's really tough to see and look after those people who are being treated for chronic graft-versus-host disease for a number of years, and then, you know, have sort of an unfortunate terminal event and die. It's really, I think as healthcare professionals, it's often one of the most challenging things of looking after people who have graft-versus-host disease. So you talked a little bit earlier about sort of common organs that are affected with acute graft-versus-host disease. I guess it would be really nice just to have kind of a bit of an appraisal of sort of common signs of graft-versus-host disease, common signs and symptoms.
Okay, sure. So, I mean, acute GvHD, well, typically it is pretty much clear that it's acute GvHD because usually affects either skin, so it occurs as rash. Well, it's a typical rash, like red maculas, which usually itches a bit as well. Then when it affects intestines, it manifests with diarrhea, and this diarrhea can be, well, actually very depends on the grading, but it can be very severe, so that can be even a liter or 2 liters of diarrhea. So that's really something that is very hard to handle as a patient. And then there's the third organ is affection of liver. So and that's usually seen as increase in bilirubin, so disruption in liver enzymes. So basically, skin, liver, and intestine are the target organs for acute GvHD. Usually, skin can happen alone, but when you have intestine, it either happens alone or with liver, and intestine can also happen with skin, but liver almost never happens only alone. So liver usually goes with something else, so either skin or intestine. I mean, for clinicians, for transplant physicians, it is very, very clear when there's something happening with a patient. Although in this early post-transplant period, actually, you have to be, let's say, an experienced transplant physician to really see what's happening, because lots of post-transplant complications resemble a bit. So infectious complications, toxicities from drugs, that can all cause, for example, rash can be caused by some viral infection. It can be caused by drug toxicity as well. It can be GvHD, similarly for liver. So you really have to have some kind of clinical experience to know that it's acute GvHD. And acute GvHD, well, the word says acute. When something is acute, you have to react fast. So acute, let's say it's a bit of an emergency. Well, maybe not like myocardial infarction but in hematology, acute GvHD is something where you have to admit patient promptly, do the necessary diagnostics, start the treatment not on Monday, but on Saturday if the patient is admitted on Saturday, because otherwise, if you don't, let's say, suppress this immunological reaction that is happening, it can really get only worse. So this term acute means that you have to really react promptly and, let's say, aggressively, with aggressive immunosuppression, because in that way you can prevent further complications, meaning worse GvHD and worse infectious complications with the treatment of GvHD. Chronic GvHD, well, the word chronic then again says that it's something that usually happens slower, develops slower, and you have some time also to observe and react. Chronic GvHD, on the other hand, is a very, very heterogeneous disease, as all the autoimmune diseases, because it can affect any organ in the body. And this is why it's not even enough to be only the experienced transplant physician for chronic GvHD. For managing chronic GvHD, you need a help from many other people. You need actually, well, I would say at least an ophthalmologist and at least a gynecologist, because chronic GvHD can affect also organs as eye or also reproductive organs. So this is something that even if you're an experienced transplant physician, you are not, let's say, well educated for doing the examination of these parts of the body. So it is really important. It's really crucial for chronic GvHD to have a multidisciplinary team of different specialists. So not only, well, at least a gynecologist and ophthalmologist, but ideally you need like a set of 10 to even 15 specialists for all organs, because managing patients in a multidisciplinary way enables well-established diagnosis, and then also the best way of managing these patients, because by talking to other specialists, you can see what is the intensity of the treatment that the patient needs to get, and also this is something that really improves the supportive care management in these patients, because this is something that is really, really important in chronic GvHD. Chronic GvHD is something that actually takes a long time, and it can be something that really impairs quality of life of patients. And this is really something that is important, because unfortunately some of the patients would say that they would not undergo transplantation if they knew how chronic GvHD is going to look alike. So this is something that of course all the transplant physicians and nurses hate chronic GvHD, I think. On the other hand, also patients who have a bit of chronic GvHD have less relapse. So if we could choose, we would choose a bit of GvHD, even chronic one. But I think management of these patients has really improved in last years with, let's say, this knowledge that we need a multidisciplinary approach with new knowledges about the biology of GvHD, and then consequently new treatments emerging, and also very importantly supportive care, which is extremely important in taking care of chronic GvHD patients.
Thanks very much, Zina. That's, gosh, such a comprehensive answer, and a lot of information there for people to digest and unpack. I'm going to hand over to Emma now for the next question.
Thank you very much. Yeah, I'm writing copious notes of things that I'm learning again today. So I have a question about what was the most unusual presentation of GvHD that you've seen, Zina? And like, how do you assess for GvHD? How does that then tell us what to do with that patient? How do we do the treatments that are prescribed? That's one big question, but interesting.
Well, it's a bit of a hard question, because I'm thinking what was maybe the let's say the weirdest presentation, but I would answer you the other way. So what was the chronic GvHD, which was actually not chronic GvHD, because I think this will help me show you to understand how important is multidisciplinary approach. Sure. So I had a patient who had acute GvHD, and then we had lots of because first line for treatment of acute GvHD are steroids. So steroids are drugs which have lots of side effects, and although they are effective and we like them because they work in most cases, they have lots of side effects, and that can be a problem. So this patient had lots of side effects of steroids that she got for her acute GvHD. And then we decreased steroids and other immunosuppressive drugs in order to decrease the side effects as well, because as I said, acute GvHD was under control. And then by doing that, she came back to the clinic with very let's say severely affected eyes. So she had some red eyes. She had problems with seeing. So we were and I was a young physician at the time. Then I presented her case to my, let's say, senior transplant physician, and then everybody said, okay, acute GvHD and decrease of immunosuppression, that's for sure chronic GvHD of the eye. You should increase the immunosuppression, do this and this. And then I said, well, okay. And then at the point we also were starting our multidisciplinary GvHD team, which actually works in a way that when a new patient is diagnosed with chronic GvHD or suspected with chronic GvHD, all organ specialists see the patient and evaluate all the organs for signs of chronic GvHD, because that's very complicated to all actually evaluate for chronic GvHD. But we're doing it with more people, it actually makes it easier. And then since her eyes were, let's say, mostly affected, and also she had some mouth problems, and chronic most frequently affected organs by chronic GvHD are actually skin, eyes, and mouth. So it was really possible that it is chronic GvHD. So she was first seen by an ophthalmologist and it's a dentist. So a dentist and an eye specialist, and then I was waiting for their call to tell me that it's now chronic GvHD of the eyes and mouth, but they said, oh no, it's not, it's actually a severe herpes infection, so herpes viral infection of both the eye and mouth. So for me as a clinician and for all my senior colleagues, I mean, red eye is a red eye, and some ulcers in the mouth can be GvHD and cannot be GvHD. But for somebody who knows how to check the mouth and has also some of the tools to do it, because ophthalmologists and both dentists work with different tools, they said, well, it's actually something completely different. And infection, you do not treat with increase of immunosuppression, you do just the opposite. So if I didn't have them, I might have done actually something that would be very wrong for the patient, because increasing immunosuppression would make the infection worse and even could make it severe and even fatal. But with having a multidisciplinary team, and this is not an easy thing, because I'm always saying this, that for me, the red eye is a red eye. But it really is like that. I cannot from the outside see, is it chronic GvHD or it's not. I mean, with experience, of course, experience helps, but this is something that always, this story, I always say it, I repeat it, because it's really something that taught me how important it is to manage chronic GvHD, completely different from everything else in hematology and in transplant, because most of the other things in transplant you can manage by yourself. I know acute GvHD perfectly, on all the transplant complications, but chronic GvHD, even with experience, you need a help of other people as well. And it's not only ophthalmologist and dentist, but in this case, this was really, really crucial to make the diagnosis. And this was a very, very severe infection finally. So it's really good that we did not, because we did the opposite actually. We then stopped immunosuppression instead of increasing it. So I hope that kind of answers your question.
Yeah, within it, it's important to make sure that we don't assume one thing, I guess, is what your point is, that you don't have this tunnel vision that only says, well, it must be this.
And that you have to actually, you cannot manage it by yourself.
Yes.
As much as experienced transplant physician you are.
Yes, that everyone's experience and specialism is really important. That's excellent. Michelle's got your final question for now, but don't go anywhere, because we'll bring you back for the quickfire round after we've had a good chat with Sophie.
Thank you, Emma. You've talked a little bit, Zina, about the treatment for graft-versus-host disease being quite complicated. And I think we all kind of identify with that. But there are some new advances in GvHD prevention and treatment. I guess we'd like to hear a little bit about those as well.
Yes, well, I mean, I would say it's in good times for chronic GvHD, because until last year, we had actually one treatment approved for steroid refractory chronic GvHD. So in chronic GvHD, we also treat with corticosteroids as first line, but as in acute, half of these patients unfortunately do not react to first line treatment. And then the problem is really what to do next, and to find an effective treatment that will help those patients also to be cured. And this was really an unmet need in transplant, so steroid refractory GvHD. Many drugs were tried in this setting, were evaluated in clinical trials, but unfortunately nothing worked better than other drugs. And until last year, we had only one drug approved in this setting. It is called ibrutinib, a drug that is used in hematology for other diseases. But even though it was approved, I would say that it didn't really enter clinical practice as much as we thought, because in real life, side effects were, let's say, special infectious complications were, let's say, something, well, in my experience at least, were something that prevented the use of that drug more than, I mean, as much as we thought it would be when it was approved. But then last and the year before that actually got the approval of two new drugs. So after having like one drug from 2017, now we have three approved drugs. Well, at least from the FDA, and these other two drugs are ruxolitinib and belumosudil. So the two drugs that have been shown to work in steroid refractory chronic GvHD, and I think that really is changing the field extremely. It's giving hope and perspective to patients who have this steroid refractory form, because these patients were really having poor quality of life, many other complications which go with active GvHD, and this is something that is really changing the treatment landscape. Also, the prevention has evolved, because last decade or a bit more have also enabled all recipients to have donors in a form of haploidentical transplantation, where actually your parent, your child, your brother who is not fully compatible can be a donor, even a cousin, if they're half. This made transplant available to everybody. But also that was thanks to a new way of immunosuppression that we are now using in other types of transplant as well. And that's called, well, I won't bother you with that, but it's called post-transplant cyclophosphamide. And it's something that is actually decreasing the occurrence of GvHD in the first place. So development of immunosuppressive treatments has also enabled other types of transplants and decreased the rate of GvHD in general. And I think the third thing was third thing that besides prevention and new drugs that I would like to mention is really development of supportive care. So in chronic GvHD in particular, there are so many things. It's nutrition, it is physical therapy, it is psychological therapy. So actually so many things that are important in alleviating symptoms of chronic GvHD. And I would say that supportive care and all these treatments are as important as the drugs that we have. So most of the care for chronic GvHD, so at least half, but I would say even more, is in supportive care. So this has also developed, and I think this is also improving the perspective for GvHD patients as well.
Thanks, Zina. No, I couldn't agree more. The role of supportive care is an absolute crucial weapon in the care for patients with chronic graft-versus-host disease. I'm interested in the new drugs. Can you just tell us, as briefly as you can, a little bit about how they work? So, because there's 3 new drugs, they're all a little bit different. We've had steroids, we've had, calcineurin inhibitors. What is it about these that's a little bit different and special about their mechanism?
Well, they are acting on some of the, let's say, enzymes, which work as some of the activation points in some of the immunological, because GvHD is an immunological, of course, reaction. So one of them works in the B lymphocytes, so the BTK inhibitor, which is ibrutinib, acts there. Then the ruxolitinib, which is the other drug, is also working in this activation of lymphocytes. And the interesting is the third drug, belumosudil, which because one of the important part, and that is, let's say, a bit of irreversible part of chronic GvHD is fibrosis, because in acute GvHD you have inflammation, let's say, and then inflammation can stop or progress. But in chronic GvHD you have the stage of inflammation and then the stage of fibrosis, because let's say that reparation goes with healing or maybe something like that, but it happens that at the end you have the fibrosis, and that's something that is horrible in the skin and in the lungs, because you have sclerosis of the skin, you have fibrosis in the lungs, and that you can't treat with any drugs, because in the stage of fibrosis the only thing that you can do is like doing lung transplant. So there are no effective drugs in reversing this fibrosis, and belumosudil is the new drug which actually works there. So it can work even in the stage of fibrosis. So in those very severely advanced stages of chronic GvHD, these drugs also work. So this is really really something which is great.
And I think, there's hope, isn't there, on the horizon for our patients and for us as health professionals, that this is attracting more attention again, and that there's new things that we can use in a measured way. Thank you very much, Zina. I'm going to hand over to Emma, who's going to bring Sophie into the conversation.
Yes, indeed. Sophie, thanks so much for, again, thanks for joining us and for being so patient. So we're going to have a little chat about children and in terms of GvHD, because that's your specialism. So how often do we see GvHD in children post-transplant? And are there any risk factors for children getting GvHD?
I think it's almost the same as adults.
Okay.
So I think you, like Sina told you, there are 4 grades. At the grade 1 and the grade 2 we accept, and it's good if they have a malignancy. If it's for something else like a skid or something, you don't want GvHD at all. So but it's almost the same, but we rarely see the grade 3 to 4, so we try to avoid it. But it's the same. I think it's just the same, because it begins with a good selection of the therapy and a good selection of the graft. Instead, for children, we always ask bone marrow as graft at first, and not peripheral blood stem cells. And bone marrow are more protective against graft-versus-host.
Well, that's really interesting. I hadn't realized that. I do not work with children. So you use bone marrow cells rather than peripheral stem cells as the first choice.
Yes.
That's fascinating. Michelle has your next question.
Thank you. Thanks, Emma. And so, Sophie, I think that brings us on quite nicely, really, to your next question, which is about the common treatment approaches for graft-versus-host disease in children.
Yeah, we also start with cortisone therapy, and then we have the difference with adults is that we don't have a lot of trials that we can include for our patients. So we are always a little bit later than the adults for the new drugs. So we have to wait when a trial comes up for children, but we have a good understanding with lots of pharmaceutical companies, and we can ask some medication in medical need or something, and they are glad to give us some medication for our patients without evidence of the treatment for children.
So like a compassionate use or something like that? Is that
Yes,
what you
yes,
mean?
yes,
So
yes.
it's possible
Compassionate use.
to get very limited access to
Yes,
some of these drugs, occasionally in
yes,
extreme or, you know, very small numbers of individual cases.
yes,
Yeah,
exactly.
okay. Thank you. Thank you, Sophie.
So yeah, my next question actually kind of also links on to that. So Zina's obviously talked about drugs like ruxolitinib and that, sorry, is it, it's not ruxolitinib, is it? It's
Yeah,
it
Yes,
is. Thank you.
Yeah.
I did hear it right. And that's not available for children.
this one is available.
It is available for
This
children.
one is available,
Okay.
yes. They were trials for children. Okay, yeah.
So what impact are those drugs now having on the outcomes for children?
Very
very
good.
positive?
Yes, yes, yes. When we see that they don't have a good response on the other therapies, and we start with rituximab, we see that they have a better quality of life and a better response. So it's a very good thing that is available for children as well. Yes.
And quality of life is obviously really
Yes,
important.
yes, very important.
And I assume that you also have a very similar approach to the supportive care and other management for symptoms in
Yes,
patients, in your children with
yes. We work
GvHD.
with the endocrinist, with all ophthalmologists, with dermatologists, with everyone is involved in the clinic of the patients post transplant. Yes.
That's I mean, they've all got such difficult names to say, haven't they?
Yes.
But
Sorry.
interesting about the endocrinologist. So, is that also thinking about the child growing up and their
Yes, the
growth
puberty.
hormones,
Yes,
puberty?
yes, yeah, yeah.
Fantastic.
Indeed, yes.
So Michelle's got the next question that probably links on quite nicely from that as well.
Yeah, so Sophie, we talk about sort of, when we think about children, we sort of often think about little children. And do we see the kind of nature of graft-versus-host disease change depending on the age of the child? So is graft-versus-host disease, let's say, in preschool children behaving a little differently from the way it behaves in teenagers, or are they really the same?
In my clinic, I see more grade 4 in elderly children that they are in the puberty, but I don't know if that's the case. Maybe it's because they don't tell quite directly that they have some problems, and it is not detected at time. With a little child who is who depends on his adults, I think you have more information or more directly information than with the pubers or something like that. But I don't know if the mechanism is something else. I don't know.
But gosh, that's really interesting, Sophie, that you say that you know, children that don't have the maturity to be able to articulate have others who find it very easy to articulate for them. But when you reach puberty and your teenage years, those children should have the ability to articulate, but find it much more difficult to do so, and are not necessarily as visible in all of those ways to their parents as the younger children are. And that's something I've really never thought about. It's very interesting.
It's sometimes shame, like how often you go to the toilet, and is there diarrhea? It's sometimes shame. Have you pain on your button or something? It's often shame and not want to, or not want to go back to the hospital as well.
Well, exactly, yes. And I mean, we have exactly the same experience with our adult patients, you know, who it's not a shame expression as such, but that, you know, they will mask problems because they don't want to go back into the hospital and spend more time there. And of course, as we know as clinicians, although we don't want patients to spend time in hospital because that comes with its own set of problems, we know that the more that there is a delay to treatment, then the longer the treatment will take to potentially be effective, potentially leading to a longer stay in hospital.
Yeah, it's true.
Yeah.
Wow.
Emma.
Yeah, that's blown my mind as well, actually, and possibly a little piece of research for someone to do in the future to see if there's an issue there. What are the cornerstones for good nursing practice looking after patients with GvHD? What do you think is something we should be doing for looking after these patients to make sure what we're doing is best practice?
I think the first step is listen to your patient, listen what they feel, what they are looking against for therapy or something, of why they don't take their medicines or don't use the creams you prescribe, or just listening is very important, because if your patient didn't want to do it, he will not do it. You can admit him in the hospital and do it for him, but when he goes home, he will not do it. So that's, I think, a very important issue. Also, look at your patient, not only speak, but also look, because in an outpatient setting, you see the patient in our hospital is 2 times a week, early after the transplant. You will notify the difference in skin, in weight. You will see it when they don't eat. You don't have to put them on the weight scale, but normally you see. So also look good. And then an important role also for experienced nurses is that when they are there is a physician in the ward, and she or he is not quite common with the graft-versus-host, you can advise him for some things to look at, because sometimes you will see they have sores in the mouth, and I often hear, okay, he has mucosite, but I think no, he can't have mucosite because his therapy was long before, and it has to be graft-versus-host of an infection, but mucosite it is not fit in this moment of his post-transplant. So you can give advice to the physician as well, and I always offer them the app to score the graft-versus-host. So and I'll also do it with the patients themselves, and also with the adults, so that they can see what is what. Okay, they don't have to know a lot, and they don't have to be you don't have to make them having anxiety about this, but you have to inform them for a lot of signs. So that's a great role, I think, for nurses, to have the experience, to tell to your physician as well, to tell to your patients that I think we have to look for this a little bit further to see if it's not this or this, and don't give anxiety. Also, it's also important, I think.
I think that's a really great summary about nurses using their innate skills, listening, communication. So fantastic. Thank you very much, Sophie.
So we're going to now move to the quickfire round. These are sort of 5 questions. We want fairly short answers for these. First couple of things that come to mind. And I'm going to start with you, Zina, for the first question. So what factors have the greatest impact on quality of life for those with graft-versus-host disease? And really just looking for a couple of things here.
Okay, so management of chronic GvHD. So multidisciplinary management of chronic GvHD, I think, is the most crucial. I would say psychological support and also family support. So the surrounding of the patient.
Thank you very much, Zina. And over to you, Sophie. Same question.
The early detection of graft-versus-host and easily be contacted easily. So when there is a problem, that they can reach you with a problem, and then you can search for a good solution with the different physicians or the different kinds of health workers.
Thank you very much. Sophie, over to you, Emma.
Okay, so next question in the quickfire round. What is one thing you wish you'd known before you met your first patient that had GvHD? And we'll go to Zina for that one first.
Wow.
Sorry.
What a hard question. Well, maybe the most important thing would be for me how difficult their life gets with chronic GvHD, because I always remember patients who although I mean I'm the one prescribing them medications and taking care of them let's say in a serious way, what they actually always want most from me is for me to talk to them and to give them support, and to just listen to their symptoms, and even if I don't help them, just to well, basically to have time to listen to them. So I always remember situations of some of my younger patients who were saying to me, "It's fine, you can take the others before me. I will wait to be last." And that's because when they wait to be the last, then I have the most time for them.
Yeah,
it's sad actually, because what they actually want from me is to talk. That's what they miss, because what we are very, very overwhelmed with. I mean, the most important for me is to see the test of the exams and to prescribe medication. This is something what I have to do is to get the disease under control. But this is for them. This is equally important. So this always made me a bit sad how they wait for me, even if they have to wait for like a few hours just to have those maybe 15 minutes more, which is really actually something that I realized after working for some time with these patients, and then maybe I would approach them differently if I had this perspective of what's really also important for them. Maybe that, yes.
Good answer. And Sophie, what about you?
If I remember a patient who has a lot of lesions on his skin, and I was suffering for him, because it's a huge work for the nurse when they are all covered with lesions to take care of them. It's like a burned patient, and I feel sorry for him, and I wanted to take away a little bit of his discomfort and say, and I would have the opportunity to say it will come good again, but you can say that, because you don't know if it goes good. And when they have a lot of lesions, they leave our ward and go to the ICU. So you lose also a little bit of contact of these patients, and often they get a tube, so you can't communicate it with them anymore. So I felt very loved, I will say, so as nurse, and I had the feeling that my care was not good enough. Also, you know you can't do anything about it, but you feel lost. I think that was my first experience with a patient with very lots of lesions, and a feeling of loss.
So it's interesting, isn't it? About what you've both brought out there is that the thing that you wish you'd known was that our patients value us when we're human beings, and you know, I think that that's also something that's really important in the way that we look after all of our patients, that they really value those qualities in their doctors and in their nurses. Thank you very, very much. So next question is, what do you think is the main barrier, or one of the main barriers, to delivering care to patients with graft-versus-host disease? Zina.
Well, I mean, I always think of chronic GvHD patients. I think the main barrier is maybe this perspective that supportive care is the at least as important part of care as drugs, as medication that we give to treat GvHD, because those drugs are not working, and they're also the outcome is not improving, and the patients are not getting better if they're not getting all the supportive care with the chronic GvHD along with the drug that we give them. So I think just this comprehension that chronic GvHD is such a complex disorder with all these parts that need to be assessed. I think it helps you, I mean, understand why something is not working and how you could make it work in some patients better. So that's it, I think.
Thank you very much, Zina. And Sophie.
For me, also the supportive care and helping with little adjustments and for daily life things, or for so the quality of life will go up a little bit, and keep on being there for the patients and their family.
Thank you very much. I'm going to hand back to Emma.
I've got a flipped question. We're going to think about patients. So what do patients most worry about when they're experiencing GvHD? Zina?
Well, I think they worry. I mean, will their life ever be better again, and will they ever be like they were before the transplant? Because I mean, we give them cure. We said, well, now you're cured from a hematological disease, let's say 2 years after transplant, and they are feeling worse than ever because of the side effects of the treatment and because of chronic GvHD. And then we say, well, you know, it's an autoimmune disease that affects literally any organ, and it takes long to get better, and it really, for them, it sounds, I mean, horrible. So what I usually tell them, which I've seen, because the crucial thing is actually patience, and it really does get better. I mean, in chronic GvHD, it really does happen that immunological tolerance eventually emerges and chronic GvHD surrenders. But in some patients, it takes 2, 3, 4, 5 years or even more. But it does happen because, I mean, most of those patients, even if they have the immunosuppression, which is pretty severe for a long time, at the end you really see that something is happening, at the chronic GvHD is going away. So this is something that I try to tell them when I want to make them feel better, is that this is going to pass and this is going to be better eventually.
So they will feel better. Sophie, what about your patients?
Yeah, that's a little bit more difficult, because the child doesn't have patience to wait when it will be better, and they want to be a normal child after the transplant. And mostly they put in their mind that the transplant is the last part of their treatment. So
Yeah.
after that, they will be cured and they will be doing everything they could do before, of everything another child of his or her age will doing. But that's when they have graft-versus-host or they have chronic graft-versus-host, it's sometimes not the possible. So they are feeling a little bit angry because that was not the thing we prospected for them. So, and also their self-esteem will be low, and that's something very important to take in account, because we want them to be happy, to be a normal person with a future. So, and sometimes you see that they give up and they don't take their medicine anymore because it's not helping, and so on. So you have to have some psychologist support to deal with it and to go in discussion from, okay, I know it's very hard for you, but telling something it will go well in the future is a very difficult thing to say to a child. Yeah.
So it's about that managing expectations of the child depending on their age and things. Yeah. Okay, Michelle's got your very last quickfire round question, so I'll hand you over to her.
So we're almost over the finish line. Last question. What do healthcare professionals worry about most when caring for people with graft-versus-host disease? And I'm going to come to Sophie first for this one.
I think the feeling of we are helping them to cure from their disease, and now they have another acute or chronic disease after transplant, and that sometimes we know that is one of the complications in the transplant, but it's always a pity that, not a pity, it's always hard to see patients with severe chronic graft-versus-host. And when you look at photos from before and after, it will be a huge difference, and you say, is it? But then we use quality of life assessments, and also this persons of a lot of this persons have a quality of life. So that I sometimes give to the nurses at ward. So we see it like, okay, this is not quality, but it's not quality for you, but it's quality for her. And if there's the choice of life or death, then mostly you will live, a child will live. So but it's difficult, and it's a big worry when we see that a patient developed some graft-versus-host lesions on the skin, and you see it coming up. We are always afraid that they will be the one who will not be cured, will be cured for his disease, but will die in the end just of the complication, and that's hard.
Yeah.
Thank you, Sophie. And over to you, Zina. What do healthcare professionals worry about most when caring for people with graft-versus-host disease?
So the answer is well, I think nowadays I mostly worry if before transplant, actually, if the patient understand what they're going to go through, because I mean, when I was starting transplant, I was always telling patients, transplant is going to cure you. It's the best thing. But I mean, with some experience, I really realized how important it is to prepare the patient for everything, to really take time before the transplant, and to make them aware of all the complications. I mean, not in a negative way, in a positive way, with a perspective that these complications will happen, but that we know how to manage them, and that they will pass in time in most of the cases, but also to make them aware of the whole, because they need to be aware that this is really a very, very hard, difficult journey, and that I think preparing them better makes them handle the complications and GvHD better as well.
Absolutely.
Yeah, I think it's really hard to convey to patients what graft-versus-host disease feels like, what that experience can be, and how complicated it can be. But I absolutely agree. You know, offering as much preparation and information as feels reasonable or is reasonable in order that patients can make fully informed choices before they head on into transplant. We've finished. What an amazing conversation. Thank you both of you very, very much indeed. You've really shared a lot of experience and a lot of knowledge, and I really hope that people that are listening in to the pod have picked up what we've picked up from this conversation. So thank you both very, very much indeed, and we're going to let you go now. Thank you.
Thank you, guys.
Thank you so much. It was a pleasure.
Thank you.
Thank you again.
Well, what an amazing podcast, Michelle. That was so good.
Yeah, incredible. Gosh, lots to think about there and process, I think. You know, graft-versus-host disease is a massive topic, isn't it? And I feel like we've only scratched the surface today, but also gone into a lot of detail on the things that we covered. And it was a real pleasure and a privilege to welcome Zina and Sophie into the conversation today. Really, really great. Really,
I agree. I think we're probably definitely going to need to do some more on graft-versus-host disease, and it would be great if our listeners could tell us if there was anything in today's episode that they wanted to hear a little bit more about. I mean, I think I knew that a little bit of graft-versus-host disease would be okay, and as actually quite a good sort of prognostic indicator. And again, you know, this approach, this MDT approach for in particular chronic GvHD is obviously so important. Those developments that we've got, the new drugs and the new processes, sound great. Improved outcomes. We love an improved outcome, don't we? But that management of those
it's very exciting, and very exciting, and potentially the improvements to quality of life of people who are living with graft-versus-host disease. You know, not forgetting that treatments that are being developed can be given as outpatient treatments. And so, you know, the financial toxicity and challenges with venous access and transfusion support that patients experience with some of the other treatments don't need to be consideration. And so, you know, I think that's all offers quite a lot of hope and is pretty exciting, actually.
Really exciting. Really exciting. So, yep, anyone out there, if you want us to pick up a particular part of the conversation from today and do a further sort of dive into that, please do let us know. You can contact us on the usual platforms, so you can comment on the podcast on Spotify or on YouTube, and you can contact us through the EBMT website. And again, if you've got any topic ideas for the future, we have some ideas, but as always, we want to know what you guys want to hear. And we are looking forward to recording our next podcast, but we're not going to tell you what that is yet, because we like to keep these things a little bit of a surprise. So thank you very much for listening. Thank you to the background team for the wonderful editing skills that they have and for making us sound super professional, right, Michelle? Not sure I always do, but they make us sound great. And thanks for being my co-host again, Michelle. It's always fun. Always fun.
Thank you again, Emma. Thank you.
No worries.
Bye.
We'll see you guys all soon. Bye.